Medicine at the University of Pennsylvania, and I have the honor of being the 2001 ASH Secretary, and so I'm happy to moderate this session. Before we begin, I'd like to remind everyone to turn off their cell phones. I think I'll do the same as we're beginning. So this is the session on examining novel treatment techniques for bleeding and clotting disorders. In the interest of time, what we're going to do is we're going to present all four sessions first, and we'll take questions afterwards. First, we'll take questions from the floor here, and then we also have people who have dialed in because they phoned in because they were unable to attend the meeting, and we'll take those questions afterwards. So we have some very exciting presentations that will be done today. The first presentation will be done by Dr. Celia Beccattini. So I'll just say that previously aspirin has been shown to have a role in preventing arterial thrombosis, that is heart attacks and strokes, but its role in venous blood clots, deep venous thrombosis, has previously been unknown. In sort of surprising work, Dr. Beccattini and her colleagues have demonstrated that aspirin may have an effect in preventing recurrences of blood clots after standard anticoagulation therapy has been terminated. This abstract is number 543. Next, Dr. Koji Ito will discuss how he has successfully generated human platelets from induced pluripotent stem cells and infused those platelets into mice, showing that they have functionality. So the reason this is so important is that platelets are always in shortage. Donated blood platelets have a very short lifespan, and so we're always looking for abilities to increase the world's supply of blood platelets. And this has the potential of marching us forward to a day when we might be able to eliminate worldwide platelet shortages. The next abstract is given by Dr. Amit Nathwani and his colleague Andrew Davidoff. So this is a very exciting gene therapy trial for the treatment of hemophilia B. So hemophilia is a worldwide blood disorder, affects probably about 400,000 people. The treatment for it is rather invasive. It's extremely expensive. Think in the order of about $100,000 US a year on average. Dr. Davidoff and Dr. Nathwani have developed a technique for potentially permanently curing patients of hemophilia B. What they'll describe is an updated trial that shows 6 patients who have been successfully treated using a viral technique to restore the gene that's missing in hemophilia B. Finally, Dr. Pierre Morton-Sansat will present an interesting trial that demonstrates that the use of these so-called clot busters at the initiation of anticoagulation therapy may prevent the recurrence or the occurrence of post-phlebitic syndrome. And so I should tell you that although we're fairly good at treating blood clots, probably about a third of patients are left with persistent symptoms afterwards. Dr. Sansat and his colleagues will present some evidence that suggests that the early use of these fibrinolytic or clot-busting agents may actually improve the long-term outcome in patients with this disorder. And so I'd like to begin. I should tell you, I neglected to mention that Dr. Koji Ito's talk is abstract number 2, Dr. Nathwani's talk is abstract number 5, and Dr. Sansat's talk will be in the late-breaking abstract session, and it's abstract number 1 in that form. And so now, Dr. Beccattini, I'd like you to begin. I will remind you that there are people listening via phone, and so if you could try to speak into the microphone, that would be great. Thank you. Oh, why don't you come on up here, sir?
So thank you very much, Dr. Abraham, and good morning, ladies and gentlemen. We are talking now about a disease that is commonly called venous thromboembolism. Venous thromboembolism occurs in about 800,000 of people in North America every year, and it is composed by 2 different clinical conditions. The first being vein thrombosis, that commonly presents as pain or tenderness in a leg. But this condition may be complicated by the migration of a piece of the blood clot from the vein of the leg up to the heart and then to the pulmonary circulation, this inducing the potentially fatal condition that is commonly called pulmonary embolism. Pulmonary embolism occurs in about 50 to 60% of patients with venous thrombosis and may be fatal in about 20% of the patients. Currently, in order to treat these conditions, we have drugs that act by blocking coagulation of the blood, and these are mainly represented by warfarin. Warfarin is very effective in reducing the recurrences of venous thromboembolism, in preventing the growth of the thrombi that have already formed in the veins of the legs, and during a standard treatment in months, it's also effective in dissolving thrombi. But people on treatment with oral anticoagulants experience about a 3% rate of major bleeding every year. When I talk about major bleeding, it may be major gastrointestinal hemorrhage, but also the potentially fatal intracranial hemorrhage. So the first limitation of a standard, indefinite, long-life warfarin treatment is the potential for harmful complications. And the second inconvenience of long-term standard warfarin treatment is the need for frequent blood workup and medical visits in order to check for the INR and in order to adjust the dose of the drug. Based on these limitations, patients who experience a first event of venous thromboembolism are usually stopped on treatment after about 6 to 12 months of treatment. So we wanted to test the hypothesis of whether aspirin, that is a very well-known drug, very well-known because we have now data on millions of patients treated with low dose of aspirin for secondary prevention of myocardial infarction and stroke, and it is a simple therapy because it does not require laboratory monitoring, no need for dose adjustment, and it's safer than oral anticoagulants, as the risk of bleeding complications while on aspirin therapy is lower than 1% per year. So we wanted to explore whether aspirin therapy, when given at a dose of 100 milligrams per day, that is a bit higher than the dose of baby aspirin, but it is much, much lower than the dose of regular aspirin, that is 375 milligrams. So we wanted to explore whether this dose of aspirin can be effective in reducing recurrences of venous thromboembolism. And we found in our trial, there was a multi-center, randomized and double-blind trial coordinated by Professor Giancarlo Agnelli of the University of Perugia, whether this treatment may reduce recurrences of venous thromboembolism. And we found that aspirin reduced the incidence of recurrences by 40%. We are really convinced that our results will have a clinical impact. First of all, because we know this is the first observation, this is a novel achievement in the field of clinical medicine. But indeed, as I said, the majority of patients are left without any treatment after 6 months of oral anticoagulant therapy. So with aspirin, a drug that is low cost, safe, and I would say available worldwide, we can reduce by 40% the incidence of recurrences of venous thromboembolism. And that's all for me.
Thank you very much, Dr. Beccattini. As I remind everyone, we're going to have questions that will be afterwards. And so we're going to proceed to the second talk. Dr. Koji Ito will present his work on inducing platelets within the laboratory. Welcome.
Thank you very much. And just please see the provided paper, so each one step by step, so that I can explain according to the provided papers. From the second slide, so I can start the explanation. So basically, the IPS technology allows us to attempt the innovative therapy models in hematological disease treatment. So in principle, iPS cell can provide the creation of the HA identical donor derived iPS banking for variable patient treatment. And also, this is a very nice source for the generation of platelets for transfusion, particularly in patients requiring the repeated transfusion. Also, this technology enables the gene therapy model after gene collection from the patient-derived iPS cells. So next slide. So the one potential main reason why we try to make iPS-derived platelet transfusion system is that these platelets are nucleate cells. They can become irradiated before transfusion to prevent the contaminating T lymphocytes killing. And also, this irradiation could kill the remaining undifferentiated iPS cells beforehand. Because sometimes iPS cells could induce the oncogene transmission after in vivo transmission or transformation. So in addition, so platelets has to maintain at room temperature, particularly very narrow window between 20 and 24 Celsius degree. So they have a very short shelf life during which they are available for transfusion. This situation leads to the discontinuous supply or lack of the platelet concentrate for transfusion, particularly in the situation of emergent or repeated transfusion. So in addition to these reasons, so the iPS-derived platelets can prevent the infection associated with the use of donated blood, and also that they can be useful for the drug delivery system in the future. Therefore, we tried to make iPS-derived platelets. So, and also that we also started the project to make platelets from human yeast cells. So please see the generation of functional platelets title slide. So we recently determined the methodology of the iPS-derived platelets and also which can contribute to the thrombus formation in mice model with thrombocytopenia when they are transfused in the mice model. However, so our technology just allowed the very limited number of megakaryocyte and platelets in vitro. So you can see the slide of the title past our challenge. So in calculation, the approximately 10 to the 5th 10 centimeter dishes are required for the generation for the one patient platelet transfusion. This is a crazy number. Therefore, we changed the strategy. Please see the one potential solution slide. Our proposal is to make a self-replicating progenitor of megakaryocytes as a starting material of platelet supply, which could be a master cell banking in the future. So, we focused on the role of CMYC on megakaryopoiesis and platelet production. Please see the title reported model in mice slide. So when we went back to the mice model of role of CMYC on megakaryopoiesis, in transgenic mice or knockout CMYC, both models show the very similar phenotype, showing the impaired maturation of megakaryocytes and increased number of certain platelets. They are controversial about the role of CMYC on megakaryopoiesis. So finally, we determined the role of CMYC on megakaryopoiesis and platelet production. Please see the title, role of CMYC in megakaryopoiesis, the last two slides. So we determined the role of CMYC. So the appropriate range of CMYC activation, particularly at MEC progenitor level and thereafter decline, are indispensable for the normal platelet production, at least in vitro assay. Therefore, we hypothesized that the CMYC activation at MEC progenitor level without excess level are very important, and this situation may lead to the continuous self-renewal replication at MEC progenitor level. Finally, we determined the gene cassette of inducing the MEC-progenitor cell replication at MEC-progenitor level. So gene cassette was CMYC plus BMI1 polycomb gene. So by using this cassette, we have succeeded in the creation of the MEC-progenitor cell line, so as shown in the last slide. So they showed the exponential growth in CD41 megakaryocytes. And after gene cassette was turned off, they can be differentiated to mature phase with polyploidization. But finally, so this MEC-progenitor cell line can release the functional platelets. So my fellow is going to present tomorrow about the functional result in the plenary session. Thank you very much for your attention.
Thank you, Dr. Ito. I'd like to now proceed to abstract number 5. It's going to be presented by Dr. Nathwani and Dr. Davidoff. This is the results of their gene therapy trial. Dr. Davidoff.
Thank you, Dr. Abrams. I'll present briefly the results of our clinical trial of gene therapy for hemophilia B, and Dr. Nathwani will present in greater detail tomorrow at the plenary session. So by way of background, hemophilia B is an inherited bleeding disorder that results from defect or deficiency of clotting factor IX. The consequence of that, of course, is significant bleeding for those patients afflicted with hemophilia B. For the vast majority of patients, that relates to prolonged bleeding after traumatic events, even very minor trauma. But in a subset of patients with hemophilia B, those with severe disease who have levels of factor IX activity less than 1% of normal, not only can that be prolonged bleeding in response to trauma, but can also be spontaneous bleeding without apparent inciting event. It most commonly occurs within the joints. And the chronic blood in the joints leads to very debilitating arthropathy for these patients. But in addition, there can be spontaneous bleeding within the brain that, when it occurs, is often fatal. So the incidence of this disease is about 1 in 30,000 males. So that translates into about 5,000 patients with hemophilia B in the United States. Probably between 100 and 200,000 patients worldwide. It's a little harder to quantify that number in the developing countries. But hemophilia B is particularly amenable disease to a gene therapy approach for some of the reasons that are listed on the slide. First and foremost is the fact that it's a chronic disease of protein deficiency, and so continuous replacement is required in an effort to cure patients, and that's something that gene therapy can achieve. In addition, one doesn't need to correct the missing protein to levels of 100% to achieve a significant impact for those patients. Well, we have chosen to use an adenoviral-associated vector, or AAV, as the vehicle for transferring a normal copy of factor IX to the recipient patients. We have favored AAV because, for a variety of reasons, including the fact that despite it being endemic to humans, it doesn't apparently cause a disease in humans. In addition, it has a great tropism, a propensity for infecting the liver, and the liver, in fact, is the normal site of factor IX synthesis and the desired target of our gene transfer. The AAV vectors don't themselves make other viral proteins, so at least in theory, this vector system is less immunogenic. But most importantly, of course, for this project is the fact that AAV has been shown in many preclinical animal studies to generate long-term expression of the transgene that's being transferred. Well, in fact, AAV has been used in several clinical trials for hemophilia previously without, I think, clear success. And so our trial has differed in design from those previous trials in a number of important aspects. So the previous clinical trials used AAV of serotype 2. It was the first AAV serotype to be identified. However, others have been subsequently identified, and in our trial we're using AAV serotype 8. And the reason that we think this is important is for a variety of reasons, including first and foremost the fact that natural infection with AAV8, at least in humans, appears to be a very rare occurrence on the order of perhaps 10%. And in fact, one of the very important screening criteria for entry into our trial is demonstrating an absence of a prior infection with AAV8. In addition, there are a number of important biologic characteristics of AAV8 that make it well suited for our trial, including the fact that it transfers our gene of interest, but then gets degraded very quickly. And additionally, it doesn't seem to be able to infect immune regulatory cells, and that may be a very important issue. We've made a number of contributions or changes to the design of the expression cassette. We are using a very small but potent liver-specific promoter so that expression of the factor IX protein only occurs within the liver. We've used a self-complementary vector genome design that we feel improves the efficiency of the transgene expression. We've changed the coding sequence for factor IX using a codon-optimized strategy, using codons that are more frequently translated in eukaryotic cells. And we believe that that combination of changes has really improved the efficiency on a per vector genome basis in terms of achieving factor IX expression. And finally, because of the great tropism of AAV8 for the liver, we've been able to administer vector by a simple peripheral vein infusion and still get the desired result, that being the vast majority, greater than 99% of vector copies end up transducing liver cells. So almost 2 years ago, we opened this clinical trial, a phase 1/2 clinical trial. And potential enrolling sites included University College London, St. Jude Children's Research Hospital in Memphis, and Stanford University. To date, all patients have been treated at University College London. We gave vector, as I mentioned, by simple peripheral vein administration without coverage with immunosuppression. The primary goal, of course, in this phase 1/2 study was to demonstrate the safety of this approach, but secondary aims included measuring the levels of factor IX expression, monitoring for immune response both to the viral vector and the factor IX protein, and to look at the distribution of the vector throughout the body and in particular its clearance through various excretions and secretions. So 6 subjects have been enrolled thus far, 2 each at sequential increasing dose levels that are listed in the slide. And just to clarify, in the slide, the slide is using an old nomenclature in which we titered the virus based on PCR analysis. We currently are using a gel a methodology for titering, and that gives almost a 10-fold higher estimate of the dose. So I think in our abstract and manuscript and in Dr. Nathwani's presentation tomorrow, he'll talk about 10-fold higher numbers of vectors administered at each of the dose levels. So to summarize our experience with these 6 participants, first and most importantly, the approach has been very safe. Each of the 6 participants tolerated their vector administration without consequence or acute toxicity. As far as factor IX activity, we were pleased to see that there was increase in factor IX activity in all subjects. So these were subjects who had baseline factor IX activity levels of less than 1%. They are all expressing now on the order of 2 to 8%. In addition, all of the subjects prior to enrollment in the clinical trial were on routine of prophylactic factor IX infusions, generally 2 or 3 times a week, to ward against spontaneous bleeding episodes. In 4 of the 6 subjects who have been treated, they've in fact discontinued their use of prophylactic recombinant factor IX therapy without evidence of spontaneous bleeding. And in the other 2 subjects, they've been able to significantly increase the interval for administering recombinant protein from 2 to 3 times a week to once every 10 days to 2 weeks. With regard to vector clearance, we did detect vector in nearly all bodily fluids and secretions. However, they were cleared and stayed absent after about 2 weeks. And then the final issue has to do with the immune reactivity to liver cells that were transduced by the vector. And we did see in at least 1 patient in the high-dose cohort evidence of T-cell mediated immune reactivity against the transduced hepatocytes. This manifests itself in an asymptomatic elevation of the serum liver enzymes in that patient, suggesting a degree of liver inflammation. We started that patient and the other patient in the high-dose cohort on a very short trial or course of steroids with prompt resolution of the evidence of hepatitis and maintenance of the transgene expression in those patients. So we feel that these preliminary results are very encouraging. It clearly shows that this approach is safe, and we've demonstrated with 2 methods, measuring factor IX activity and clinically dispensing with the need for prophylaxis in at least 2/3 of the patients, that it is an efficacious approach. We do remain vigilant and concerned about the issue of T-cell mediated immunity to transduced hepatocytes, and we'll continue to monitor this in future subjects, as well try to understand both the mechanism and whether certain patients, for whatever reason, might be predisposed to this. But our immediate plans are to enroll additional participants to the high-dose cohort and study them very carefully for, in particular, these 2 issues, factor IX activity as well as immune reactivity. Thank you.
Thank you, Dr. Davidoff. So our last talk of this session will be abstract number 1 in the late-breaking session, and Dr. Sansad's going to present it.
Deep vein thrombosis is a condition that affects the deep vein, mostly of the lower limbs, and which occurs in approximately 1 per 1,000 individuals per year in the general population. So that means that in the United States there are somewhat around 250 to 300,000 affected individuals per year. Current guidelines recommend use of anticoagulant therapy, which really stop growth of the thrombus, but really does not dissolve the clot. So this means that a great number of the patients will have residual vein thrombosis after treatment. And most of the patients will also have damage to the valves, and this will, over time, mostly probably years, lead to a condition which is called post-thrombotic syndrome. And this is characterized by pain, swelling of the leg, cramping, sometimes eczema, and also in some severe cases venous ulcers. Systemic Clotlysis has been used in the past, and this was shown to reduce post-thrombotic syndrome. However, this was associated with significant bleeding complications, and this was unacceptable, and therefore this treatment is no longer used. But 10-15 years ago, treatment with catheter-directed thrombolysis was introduced, in which a catheter can be introduced into the vein of the lower limb and along the clot, and by that a clot lysis agent can be introduced directly into the clot, and we can then deliver a much lower concentration of the clot to the patient, and probably this can reduce the bleeding complications. And this is what we wanted to do. We wanted to test whether catheter-directed thrombolytic therapy on top of current best medical therapy using anticoagulant therapy and the use of elastic compression stockings could reduce the post-thrombotic syndrome. So we randomized actually 209 patients, 101 to Clotlysis treatment, and 109 to standard medical therapy. And these patients have now been followed for 2 years, and they will be followed for 5 years. There were two primary outcomes. What we really wanted to look for was whether we could prevent development of post-thrombotic syndrome after 2 years. And the other outcome was whether we had open veins after like 6 months. So when we started the trial, there were no really standardized measures how to do this. So we developed standardized measures that has been adopted by also other investigators, for instance, the American ongoing ATTRACT trial, where we used the Villalta score for assessment of post-thrombotic syndrome, and this is a scale which has been adopted and developed and validated by the International Society on Thrombosis and Hemostasis. And the other outcome was to look for open veins, which we did by looking for flow in the veins and compressibility by ultrasound, and also by outflow obstruction by air plethysmography, which is another technique. So this is the background, and what we found after 2 years was that the post-thrombotic syndrome was reduced from around 56% in the control arm down to 41% in the thrombolysis arm. And this corresponds to an absolute risk reduction of 14.5% in post-thrombotic syndrome. And this means that we have to treat 7 patients to prevent 1 post-thrombotic syndrome. And when we looked on the other outcome, which was the open veins patency after 6 months, we found that 2/3 of the patients with thrombolytic therapy had open veins, as compared to 40% of the patients with who did conventional therapy. And we could also show that post-thrombotic syndrome after 2 years was related to whether there were open veins. So those patients who had open veins after 6 months, they had less degree of post-thrombotic syndrome after 2 years. There were backside of the story. We had a few bleeding complications. 3 were characterized as major bleeding complications. One wall hematoma, and one bleeding at the puncture site, and also compartment syndrome of the leg that necessitated surgery. We believe that for the first time that we really can say that we have an effective treatment, shown that this treatment is working to prevent post-thrombotic syndrome. I would like to say that so far studies on deep vein thrombosis has always used surrogate endpoints. They have just been looking for whether you have recurrent thrombosis, but they never been looking for whether what is happening to the patient. Will they have a long-term sequelae? So I think this is also I think our study really shows that for the future we should use also functional outcomes in clinical trials on deep vein thrombosis. Yeah, I think I will stop there.